during the Q&A period. During the Q&A session, please place those in the chat and we will review those and respond after the holidays. This presentation is a joint effort between the second level review team and the CDI team. And with that, I will turn it over to Marquita for some opening remarks.
Kim, thank you so much for helping organize this meeting, and we just appreciate the opportunity to get to spend a little bit of time with you all today to go over some documentation tips. So I'm not going to take up time, but I appreciate all of the efforts of everyone that's worked so hard on this presentation. So I guess we can get started. Thanks again.
Okay, great. Thank you. Can everyone see my screen?
Yes.
Yes.
Okay. Briefly is the agenda. We kind of went over that. So we're going to jump right in and we will start off with, oh, excuse me, sorry. Here's our, these are our team members that are here and that will be presenting today, the CDI and the second level review team. And with that, we will begin with Tina Welch, if you would.
Good afternoon, I'm Tina Welch, and I work collaboratively with the CDI and coding teams as a second level reviewer, and I'll be speaking to the documentation on sepsis. Next slide, please. Did you put it?
Mm-hmm.
Okay, sorry. Sepsis are you ready? Sepsis remains to be the #1 actual diagnosis challenged and denied from external auditors on basis of SEP2 versus SEP3 criteria. UAB has adopted the SEP2 criteria for establishing and diagnosing sepsis. In this presentation, I will be speaking to the SIRS criteria as we talk about conditions other than a systemic response. Next slide, please. A case study is a 45-year-old who presents from home with fevers, weakness, tachycardia, and his impression as having tumor lysis syndrome, concern for pneumonia, as well as elevated temperature of 102, as well as a respiration. ml. On day 1, the patient's concern for pneumonia is documented, as well as tumor lysis syndrome. On day 3, documentation now brings in, as well as possible pneumonia, tumor lysis syndrome, and resolved nausea and tachycardia with AKI. Documentation opportunities present here for prompting a query to the provider in reference to the SIRS response on admission as to what condition may be responsible, as we are having documentation stating concern for this and concern for that. Next slide, please. The following query example will present and show that there are relevant indicator support, including the risk factors as well as treatment and the actual response of the SIRS that is mounting on admission. In remembering the SIRS criteria that presents itself on admission, when looking at the SIRS criteria, I cannot explain how important it is from a provider standpoint to acknowledge those SIRS response in reference to a possible other cause other than sepsis. In conditions that present, such as cancer and tumor lysis syndrome and other conditions that can mount the same response, sometimes clarification is needed. In this case example, there was clinical indicators may be supportive that the SIRS response was possibly due to the tumor lysis syndrome. Sepsis did not come into play until the 3rd day of admission. The query was prompted and the question was asked to the provider to clarify the diagnosis of sepsis. So if sepsis was there and that was what was being treated, the question was to provide the diagnosis of sepsis clarity. Sepsis due to possible pneumonia, or was it SIRS due to a non-infectious process and the cause was tumor lysis syndrome that was also present on admission? And would it be unable to be determined? And there would always be an option to be given to the provider. Next slide, please. Documentation tips for understanding, I guess, the documentation needed to support sepsis or even the surge response. When sepsis is being considered, the underlying condition and cause needs to be documented by the provider if known. Also, if it is documented as meets surge criteria or only meets sepsis criteria, we ask that you steer from this term of knowledge simply because it does not establish a diagnosis of sepsis. If you're considering severe sepsis, please document the organ dysfunction or failure that is linked to sepsis. If not, then it cannot be coded. In acknowledging the ED, it's often documented that sepsis is noted in the ED, but no further documentation. We ask that providers please address the sepsis documented in the ED and bring it forward as to is it confirmed or ruled out through the admission. Bacteremia becomes an abnormal lab value. We ask that you clarify that as a positive blood culture, and if the patient is being treated, is it sepsis? Positive cultures should link the organism if known, and please note any contaminants. Devices also need to be indicated if the sepsis is due to a device. Thank you.
Thank you, Tina.
You're welcome.
We'll move to the next presentation. Monica?
Good afternoon. I am Monica Washington, one of you all's clinical documentation specialist, and I will be discussing heart failure. Okay, ready. I'm sorry, is it showing or has my screen frozen?
It should be showing.
You have to skip me. Hold on just a minute.
Okay.
Because I still have.
You're muted now. Uh-oh. Did we lose?
No,
Come on.
I'm back. I'm
Okay.
sorry.
It's okay.
Freezes from time to time. So we're talking about the different types of heart failure, your systolic heart failure, your diastolic heart failure, and combined systolic diastolic heart failure. Of course, the acuities, acute, chronic, and acute on chronic. This is pretty much what focus is today. Next slide, please. Okay, for the case review example, this is a 78-year-old male who has a history of CKD3B and heart failure, who presented with worsening symptoms of shortness of breath, an admission chest X-ray with pulmonary edema, and a rising BNP in the last 2 weeks. The patient was admitted for hypertension urgency and heart failure exacerbation. So the October 31st H&P just said congestive heart failure with exacerbation. The 11/1/22 TTE showed that the patient had a left ventricular systolic function that was severely reduced, an ejection fraction of 25 to 30%, and a grade 1 diastolic dysfunction. Cardiology was consulted, and on November 1st, they said it was documented that the patient had an acute exacerbation of HFrEF, that the BNP was 2633 and had elevated to 3245, that the patient was given Lasix ×2, had good urinary output, but still remained volume up. Cardiology also stated in that same consult, HFrEF/HFpEF. The 1031 to 11/1 hospital medicine notes just said that the patient had a heart failure exacerbation. So the documentation opportunity was for the specificity of the heart failure. Next slide, please. So for the query example, all the information of clinical indicators were just previously given in the case review, so I won't go back over that. But as far as risk factors, what stood out, of course, a history of HFrEF, and the patient had a grade 2 diastolic dysfunction, a history of that. So based on the information, the clinical indicators, the question was presented based on your independent medical judgment. Can you further clarify the diagnosis related to these findings? The choices that were given was acute on chronic systolic heart failure, acute on chronic combined systolic diastolic heart failure, other, and unable to determine. And with the physician response was for acute on chronic combined systolic diastolic heart failure. Next slide, please. Some helpful documentation tips. It's okay to document HFrEF, HFpEF, even preserved or reduced ejection fraction, but we ask that you do not document heart failure with the EF percentage. We are not able to capture, we cannot code that diagnosis. That's not giving us a specificity. Also, your acuity with the new heart failures, what I've seen a lot of is no acuity assigned to it. If you are, if you know what the acuity, the chronicity is, please document it. If not, document that you're unsure, you're unclear, and then that way it'll just go unspecified for that time. And then also the biventricular heart failure is just the same thing. We need the type indicated, whether it's systolic, diastolic, biventricular heart failure, we're not able to capture that. So, and that's it for me. Thank you.
Thank you, Monica. We will move to the next presenter. Oh, we're returning to Tina.
Yes, you are. I will be speaking to the diagnosis of non-STEMI and acute myocardial injury. Next slide, please. The following types remain to be problematic when providing documentation support for a non-STEMI type 2, type 1. The type 1, of course, is usually caused by CAD, and it can be non-STEMI or STEMI. Type 2 is an ischemic injury that is due to an oxygen supply demand mismatch. In 2018, a new code was introduced as an acute myocardial injury code that can be due to non-ischemic or ischemic causes. Next slide, please. The following case is a 67-year-old who presents with some chest pain, hypoxia, has a history of CHF and AFib. So we see right there, we have two actual risk factors in reference to the non-STEMI or possibly demand ischemia. Exam on audible, rails, and bronchi. The troponin is elevated at 28. We have admitted for congestive heart failure as well as no EKG changes or on the EKG, but we also have elevated troponins. Cardiology is consulted and they trend troponins. The diagnosis remains as congestive heart failure exacerbation with demand ischemia, but versus a non-STEMI. The treatment was included focus-based on the heart failure. Cardiology comes in and says that they are well diuresed, and now we are stating that the troponin has trended down and we still have demand ischemia now versus a non-STEMI type 2. Next slide, please. The following is a query example that is prompted simply because the conflicting diagnosis exists between whether it's demand ischemia with the elevated troponins or is it a true non-STEMI type 2. There was non-STEMI just documented without a type, and then there was demand ischemia documented. And then by the end of it, we're back to demand ischemia versus a non-STEMI type 2. The opportunity for provider education in reference to the non-STEMI type 2s or the acute myocardial injuries or even demand ischemia is to document the underlying cause if known. Cardiology focuses the care in this particular scenario to the heart failure. However, the troponins may not signify that it's truly due to the heart failure, as the patient also had AFib and maybe it was the arrhythmia causing it. Prompted the question to the provider as, can you clarify the patient's cardiac status further? Was this truly a demand ischemia that was due to the acute exacerbation of the heart failure? Or was it a non-ischemic injury due to the exacerbation of the heart failure? Or was it a true type 2? And if so, provide the clinical indicators for ischemia, other and unable to determine. The reason being is that the non-STEMI type 2 remains to be one of the diagnoses that is being denied today. And we have seen some actually in our facility here and have looked at a couple of them. Next slide, please. Documentation tips in reference to what we can do to provide better documentation. Please include in your physical exam if there is any chest pain or any kind of ischemic changes or symptoms the patient's having. The troponin leaks and bumps, if known, need to be indicated if known as a non-STEMI type. Please link the cause. Indicate also if there's a baseline troponin. This is very helpful as if sometimes we do go back and look at the troponins from previous admissions to determine chronicity of that elevated troponins and other causes that the patient may have. Please note any significance in the EKG as to whether the changes are relevant or if they're new changes such as a new left bundle branch block. Noting that there is a new code, please specify the code if it is a non-ischemic myocardial injury. Please specify the cause, excuse me. In terms to avoid is elevated troponins only and troponemia. These two terms will not allow for a codable diagnosis and does not support the severity of your patient. Thank you.
Thank you, Tina.
Welcome.
Let's see again. Rashonda.
The topic of respiratory failure.
Rashonda, we couldn't hear you. Can you start over?
Yes, is this better?
That's great.
Okay. Good afternoon. My name is Rashonda Eldridge. I'm a CDI, part of the second level review team. Today, I will be presenting the topic of respiratory failure. Next slide, please. The diagnosis and coding of respiratory failure is a hot topic for many hospitals. This diagnosis is among the top 10 diagnoses by CMS and commercial payers that is denied. Respiratory failure can be classified into two types, hypoxic and hypercapnic, and both can be documented if applicable. Respiratory failure can also be categorized as acute, chronic, and/or acute on chronic. Providing the etiology of respiratory failure is helpful in establishing support for the diagnosis. Next slide, please. For our case review, we have a 65-year-old male who presents with shortness of breath. Notice that in the H&P, he has hypoxia and he needs a non-rebreather at 100%. And a possible HCAP is documented. The physical exam shows some accessory muscle use, some mild distress, and an oxygen saturation of 85% on room air. Further in the stay, the ICU is documented and diagnosed the patient with hypoxia, along with a respiratory insufficiency. Now, the progress notes have given their diagnoses, but there are some clinical clues that could possibly support a acute hypoxic respiratory failure. Next slide, please. So this is an example of an acute hypoxic respiratory failure query. The query is walking you through some of the clinical indicators CDI sees in the medical record to support the possible diagnosis of acute hypoxic respiratory failure. And note that these aren't the only clinical indicators that can be used to support the diagnosis. Notice that in your multiple choice options, we are also asking for the etiology of the acute hypoxic respiratory failure. And in this case, we're asking if it's pneumonia. Also make a note, documenting HCAP or CAP will not code to pneumonia. And this will prompt a query. Also, respiratory insufficiency will not code to respiratory failure, and that will prompt a query as well. You can always disagree with any of your multiple choice options given and provide another condition, and it's also acceptable to choose clinically unable to determine. Next slide, please. Some of the documentation tips for the diagnosis of respiratory failure include establishing the cause of the respiratory failure. This could possibly prompt a query due to maybe respiratory failure being part of sepsis criteria, etc. So it's important to link this to its cause. Also, indicating the type of respiratory failure is important as it provides specification for the diagnosis. Indicating the acuity of the respiratory failure helps to determine the patient's respiratory baseline and progression. Indicating the cause of intubation is very important as well, because sometimes patients are intubated for airway protection and not necessarily for respiratory failure. Documenting home oxygen needs is important because it can provide support for an acute respiratory failure if the oxygenation needs must be escalated above the patient's baseline. So for example, in our case review, the patient does not have a baseline oxygen need. The patient's O2 sat is 98% on room air. However, during the stay, the patient's oxygen needs progressed to the use of a non-rebreather, then down to 3 to 5 liters of oxygen. So that was a significant change from the patient's baseline, and it was good support for a possible diagnosis of acute hypoxic respiratory failure. The most important documentation tip is congruence between the documentation and the physical exam. The physical exam provides us with objective clinical clues of respiratory failure. Some examples: accessory muscle use, wheezing, the patient's color, tripoding, etc. Thank you.
Thank you, Rashonda. And we'll move to Crystal Reeves.
Can you hear me fine?
Yes, thank
Okay,
you.
good. My name is Crystal Reeves, and I'm a clinical documentation specialist, and I will be discussing briefly encephalopathy. All right, I will be discussing 3 types of encephalopathy that I see often in the charts: toxic, hepatic, and metabolic. Toxic encephalopathy is altered mental status or confusion that is usually caused by medications, polypharmacy, or gases. Hepatic encephalopathy is usually like an altered mental status or confusion caused by new or chronic onset liver disease. And metabolic encephalopathy is an altered mental status or confusional state, usually caused by reversible metabolic etiology, such as infection, sepsis, hyponatremia, stroke, or dehydration. Next slide, please. For my case review, there's a 67-year-old male with a history of alcohol use presenting from the nursing home due to altered mental status and decreased intake. Abnormal labs were lactic acid of 3.4, BUN of 62, creatinine of 3.3, white count of 23.4, and the CT head was unremarkable. The documentation in the chart reflected that the patient had sepsis with organ dysfunction, sacral osteomyelitis versus a UTI, and documented was acute encephalopathy improving. So in this case, the documentation opportunity was we needed to query for the type of encephalopathy. So for my query example, I listed the risk factors, clinical indicators, and the treatment for the encephalopathy. And because of the metabolic abnormalities, the choices were metabolic encephalopathy due to sepsis, other explanation of clinical findings, and unable to determine. And in this case, metabolic encephalopathy due to sepsis was the correct choice. Next slide, please. Documentation tips. It is important to show consistency in documentation. Sometimes we may see on the review of systems that the patient is alert and oriented ×4, and then down in the impression and plan, we may see that the patient is described as being confused and altered. So we need just consistency in the documentation. Also, as I mentioned earlier, is document the type of encephalopathy, whether it be metabolic, toxic, or hepatic. And also to document the etiology of it, whether it's due to hyponatremia or sepsis. And in the example of a toxic encephalopathy, it can also be a metabolic, but we have to make sure that we document the actual etiology, because a toxic encephalopathy is not usually due to sepsis unless there's something else. And delirium is not interchangeable with encephalopathy. So you can actually have both of those at the same time. So sometimes you will see our choices on our query as metabolic encephalopathy with delirium or metabolic encephalopathy only. Thank you.
Thank you, Kristen. All right. We'll return to Rashonda with malnutrition. Rashonda, you're frozen.
Oh,
Oh, there we go. We couldn't hear you.
okay. Can you hear me now?
A little bit closer to the mic, please.
How about now?
Not yet. Closer.
Is that better?
Perfect.
All right. Okay, so this time I'm going to be presenting malnutrition. Next slide, please. So this diagnosis is among the top 10 denial diagnoses by CMS and commercial payers as well. UAB has adopted the Aspen criteria to bring some cohesion to the documented diagnosis of malnutrition. The diagnosis of malnutrition utilizing the Aspen model requires two parts: clinical context and characteristics. The presence of at least 2 of the 6 characteristics in one of the 3 different clinical contexts is needed to diagnose malnutrition per the Aspen model. Each clinical context includes different variations of the characteristics to determine non-severe versus severe malnutrition. This presentation will focus on acute and chronic clinical context for documentation tips. Next slide, please. Thank you. This is an example of documentation seen in some medical records. The NICU progress note has diagnosed the patient with a protein calorie malnutrition with no acuity. The registered dietitian has diagnosed the patient with a protein calorie malnutrition with an acuity of severe based on the Aspen model. Severe depletion of body fat and severe depletion of muscle mass are 2 characteristics located within the chronic illness context. Note that the cardiology progress note, and so did the NICU progress note, describe the patient as catechectic. This is a description, and it does not code to cachexia. Next slide, please. So in this query example, you will see that we are bringing in evidence of the description of catechectic, and down in your choices, your multiple choice options, you have the option of severe protein calorie malnutrition with cachexia. We need that diagnosis. You still have clinically unable to determine, and other if you would like to diagnose the patient with something else. Next slide, please. The most important documentation tip is congruence between all documentation, including the physical exam. When diagnosing malnutrition, it is extremely important to describe your patient. Indicating the severity of malnutrition is important as well, and not documenting the severity could prompt a query. Reviewing the registered dietitian's notes for congruence of the medical record is important as well. You may disagree with the registered dietitian's assessment and diagnosis, but you must document that in your documentation. UAB has adopted the Aspen model, and it's imperative to document the clinical context and characteristics used to diagnose malnutrition, preferably next to the documented diagnosis. Thank you.
Thank you, Rashonda. Donna? Donna, you're on mute.
It might help if I unmute myself.
Great, thank you.
Sorry. Again, good afternoon. My name is Donna, one of the CDI nurses on the hospital service at main campus. I will be discussing some documentation findings and tips to help improve with documenting the persistent types of wounds and to help clarify why you may be receiving queries, particularly for pressure ulcers. Next slide. As you can see, I have included the definition of a pressure ulcer and diabetic ulcers for your review, but I'm sure you guys already know what the definition is there, but just want to kind of include that for you. Next slide. I will begin by discussing a case example. We have a 58-year-old who presented to the ED on 4/25 with dysuria, nausea, vomiting, chills. Patient has a medical history, which includes diabetes complicated by diabetic foot ulcers. The following is documented on the 4/25 hospitalist H&P. Diabetes type 2, left buttocks ulcer, diabetic wound ulcers, and a wound care consult was placed at that time. The patient did have a wound care consult on 4/26 with the documentation of left buttocks pressure ulcer, left foot diabetic ulcer, also to the left heel, and a right shin diabetic ulcer. The following day on the 4/27 hospitalist progress note, as you can see, the left buttocks ulcer and the diabetic wound ulcers was documented, but the location and the type of wound was not. The patient was discharged on 4/28 with the types of wound and the sites still not documented. So a query is needed to clarify the wounds because even though a wound care consult was done with the documentation of the type, the site, and the laterality, coding cannot code these diagnoses from the wound care consult note. Next slide. So here's an example of a pressure ulcer and a diabetic ulcer query, asking the provider to confirm the location, the laterality, and the present on admission status of the pressure ulcer and the diabetic ulcer documented in the wound ostomy consult note. Next slide. So a few documentation tips I would like to include just for the pressure ulcer. If the MD or the NP could document the location, the POA status, the stage can be taken from the wound care consult note. For the diabetic ulcers, include the wound location and if it's related to diabetes. There are also other types of ulcers that were not included in the slide, such as PAD and venous ulcers. It will also be kind of helpful if those could be included in your documentation. Thank you for your time. And that concludes.
All right. Tim.
Helps if you unmute. My name is Kim Burns. I'm one of the CDI for UAB, and I'm going to be talking to you about some tips to aid you in documentation of GI bleeds. The presence of GI bleeds and consistency and color of blood, as well as where it appears in the GI tract, confirms the presence of a GI bleed. GI bleeds can appear as melena, hematochezia, hematoemesis, depending on whether it's in the upper or lower GI tract. Documentation of GI bleeds usually consists of two parts: the location of the GI bleed in the GI tract, as well as the associated anemia. Documenting anemia due to acute blood loss from a GI bleed should always be included as a secondary diagnosis, even in the absence of bleeding on admission. For example, if someone presents with melena and a hemoglobin of 7.6 with a baseline hemoglobin of 10.5, this can be documented as acute blood loss anemia. If the patient has an iron deficiency anemia and presents with melena, then both the iron deficiency anemia and the acute blood loss anemia can be documented as a secondary diagnosis. The important thing to remember is that you must include the word anemia. If you just document acute on chronic blood loss, that cannot be captured as a codable diagnosis from the coders. Next slide. And this is just an example of how drilling down more specifically with the GI bleed will get you the maximum severity of illness, risk of mortality for your patient. If you just have melena or hematoemesis documented and you've got a separate diagnosis of esophagitis, really doesn't tell you anything. If you put the GI bleeding from the esophageal ulcer, then you've got the maximum amount of severity of illness that can take place. So the big thing to remember is that you want to be able to document what, so that you can truly capture the overall acuity of the patient you are treating. Thank you.
Thank you, Kim. And we will round out with Tina.
I was muted, sorry about that. We're going to close out with AKI and ATN documentation opportunities. Next slide, please. UAB utilizes the KDIGO criteria to establish the diagnosis of AKI. And we have different types of underlying etiologies in reference to what is the actual cause of AKI. It can be pre-renal etiology as well as intrarenal, post-renal. The creatinine trends will support based on whether the patient has a known baseline or not. So documentation is very important if known in your patient there is a baseline. AKI and ATN in the record, remembering that ATN, in order to be able to capture that, has to meet AKI criteria before we can determine whether ATN is of condition support. Creatinine levels usually will return to baseline longer in requirement when ATN is present. Next slide, please. This is a case example review for AKI. It's a 55-year-old that presents. He has a history of a renal stent. He is admitted with a UTI. He is dehydrated and is documented as renal insufficiency. His creatinine on admission is 1.2, and he receives IV fluids, antibiotics, and creatinine levels, of course, are ordered trended. Day 2, his creatinine level is now up to 1.6, which is a greater bump than 0.3. And he is slow to improve on the fluids, but he has good urine output. They increase the hydration and continue to monitor the renal labs. On day 3, the creatinine has trended down to 1.0. The discharge summary diagnosis of acute renal insufficiency with a UTI, and the patient's renal function has improved with a creatinine of now 1.0. The documentation opportunity here will prompt a query in reference to possibly support an AKI in a patient who presents with elevated creatinines and known neural stent presenting with infection, and he's dehydrated with no documented baseline. Next slide, please. The query example will provide the relevant clinical support that was identified in the record. With the patient having a ureteral stent, he has known UTI diagnosis, but he's also dehydrated. The documentation is stating that this is renal insufficiency with a creatinine of 1.2. His elevated creatinine up to 1.6, but he did improve on fluids and he had good urine output. However, they did have to continue his hydration, and by 3, he was back down. The discharge summary is still documenting that this is just an acute renal insufficiency and a UTI. He was discharged home with CPRO, and based on the clinical evidence in the record, we are asking for further clarity of the patient's renal status based on the indicators in the record. Was the acute kidney injury due to UTI, acute kidney injury due to dehydration? Was it an other renal issue diagnosis or unable to determine? Renal insufficiency does not portray the severity of your patient. Next slide, please. This is a case review of a possible opportunity for ATN when a patient has presented and they're already diagnosed with AKI in the record. Remembering that AKI criteria must be met before we can actually capture a diagnosis of ATN. This is a 45-year-old that was found down at home. That's very important to remember in this case. Patient is experiencing vomiting of blood and he presents hypotensive. He has a history, of course, of esophageal varices. His pressures systolically are in the 80s. His creatinine on admission was 1.8. His baseline is noted to be 1.2. He is admitted to GI services and he is transfused a unit of blood and given a liter of fluid. On day 1, his creatinine has now bumped to 2.0. They're continuing to trend and monitor the blood pressure as he's still slightly hypotensive and it's still documenting AKI. Day 2, the patient is creatinine now bumped again to 2.4. And now the provider is stating that we may need a renal consultation to evaluate. We have now increased our IV fluids and continue to trend the creatinine. On day 3, our creatinine now is trending down. We're at 1.6, but still not back to baseline. In day 4, we've bumped down again 0.2, but still not back to baseline. The discharge summary, the creatinine now is at 1.0 and we have a documented AKI resolved. The documentation opportunity with this case review is a possibly support of an ATN as a cause of the AKI in patients who present with esophageal bleeds, dehydrations, they're hypotensive, with an upward trend continued in their creatinine was slow to return to baseline. Next slide, please. The query opportunity example here shows the relevant clinical indicators and that the diagnosis of AKI is documented within the record. In the setting of presenting with esophageal bleed and having received blood and IV fluid boluses, as well as increased fluids and creatinine trends that did trend upward and did not follow back down with baseline until day of admission. This is a possible opportunity that ATN did exist, and it was the cause of the AKI. Based on the clinical evidence, we asked for medical judgment to clarify the diagnosis of AKI. AKI, is it due to the ATN, other etiology of renal condition, or unable to determine? The intrarenal injury in this particular case is usually ischemic, and ATN is usually the most causative diagnosis for an AKI in this presenting patient. Next slide, please. Documentation tips include for AKI, please document if the patient has CKD and if the stage is known. This is chronicity of disease and will help determine whether we're truly meeting AKI criteria. Reference the patient's baseline if known, and if it is a chronic condition as well. The KDIGO criteria remains the criteria by which we will screen and clarify diagnosis of AKI, and especially with patients with no known baseline. Please document the patient's output and response to fluids. This is very important, especially in the event of an audit on the back end. Note the underlying etiology such as dehydration, urinary tract, hypotension, infection, etc. In order for ATN to be captured, it must be criteria. Please document response to the IV fluids and if the return to baseline is these tests such as FENAs and urine. Also document the underlying cause as being noted in these below as referenced. Infection, sepsis, possible hypotension lasting longer than 30 minutes, contrast, liver disease, diabetes, hemolysis syndrome, injury or trauma, and rhabdo. I would like to speak to one thing about rhabdo and patients presenting with down rhabdo. This can increase a MST surgical, not surgical, but DRG change and shift just by documenting that in a trauma patient. So look for that opportunity as well. Thank you.
Thank you, Tina. Thank you, everyone. Great job. Appreciate everybody's time and your presentations were wonderful. So we will open up the floor to questions. You put those in the chat or come off mute. It's quite a few of you, so I don't know if someone's speaking on mute. Let's see. Okay. Okay, I'm not seeing any questions. I don't see any in the chat. Is that correct, Ryan? Is that
None in the chat.
Well, thank you, Larissa. We appreciate it. Let's see.
We got a question from Larissa. She says, this has been amazing. Thank you so much. Could you clarify a little more demand, ischemia, AMI, and NSTEMI criteria?
Do you want me to take that?
Thank you. I was looking for my mic. Thank you, Tina.
No problem. You know, like we said, this can be very complicated, I guess, to understand. It's been, you know, demand ischemia. Actually, if you have a patient, just to kind of, you know, get you started out, if you have a patient that is presenting with elevated troponins, okay, and they are above the 99th percentile, and you are looking like it's a, you know, possible opportunity that this could be a true type MI. Normally, what we ask in providers is to actually consider the diagnosis of a non-STEMI type 2 if you do have elevated troponins. If there is no elevated troponins, but yet you have an underlying condition that may be doing a demand-supply mismatch, be cautious to the fact that, do we have any kind of ischemic, documentation? Is the patient presenting with ischemic symptoms? Other documentation like that from the exam of the patient and underlying conditions will help actually us maybe determine whether a query is needed. Demand ischemia as well as the type 2 non-STEMI type 2 can be sometimes used interchangeably. Troponins elevated on some other kind of supply-demand mismatch. I hope that helped.
Tina, you were kind of breaking up there on the last couple of sentences.
Oh, I'm sorry. I was just saying what really, we like to know is if those elevated troponins that the patient presents with, number one, are they other presenting chronicity disease processes that could be, spiking those troponins? If not, is the documentation that the troponins are possibly CAD related? Does the patient have a history of CAD? Or is this patient coming in with severe anemia or any other kind of supply-demand, oxygen-demand mismatch that could be elevated too? But if the troponins are elevated above the 99th percentile, you may want to consider that this patient may be having a non-STEMI type 2.
Thank you, Tina. Ryan, do you see anything else? Okay.
There were questions about, can we get a copy of the PowerPoint? Kim answered and saying the presentation is being recorded and will be posted on your YouTube channel.
Great.
Courtney says this was great and so helpful. Love the examples. Thank you, Courtney.
Well, if there are no other questions, We thank you for your time today. We're glad to hear that this was helpful to you. And if there are any questions, please feel free to reach out to any one of us.
Thank you so much to all you guys for helping. Jody, this was great. We really like having the patient examples, the case scenarios, and we really enjoy learning that way. So thank you very much for all you've done.
Oh, it's really the team here. Appreciate it.
We appreciate
Thank
it.
you.
Bye,
Thank
Kim.
you, everyone.
Good job.
Bye.
Bye. Good seeing
Thank you,
everybody.
everyone.
Thank you.
Bye.
Jody, is it okay if I give them your email address? She leave?